Hello, I am Dr. Antonio Gallo, Associate Professor in Nutrition and Lipidologist from Sorbonne University Hospital, Pitié-Salpêtrière in Paris, France. And I am joined today by Dr. Vikesh Singh, Professor of Medicine and Director of the Pancreatology from the Johns Hopkins University School of Medicine in Baltimore, USA. In this touching conversation activity, we'll be considering the diagnosis, treatment, and patient support for familial chylomicronemia syndrome. So let's start our first section by talking about what FCS is. So FCS is a rare genetic disease that typically manifests with persistent severe hypertriglyceridemia, which can exceed 1,000 milligrams per deciliter. It affects 1 to 9 individuals per million, and it's caused by impaired function in the lipoprotein lipase, which is a key enzyme in the triglyceride metabolism. This is due to mutation on the gene coding for LPL or for any of the other cofactors that favor the activation of this enzyme. Its inheritance is autosomal recessive, and the exceeding levels of triglycerides are associated with an increased risk of acute pancreatitis, which can lead to systemic complications, including organ failure. As symptoms overlap with more common conditions, diagnosis is often delayed, mostly in older patients. So, Dr. Singh, let's discuss some questions submitted by our audience about the pathophysiology and the clinical presentation of FCS. First question is about the symptoms and tests that lead you to a diagnosis of FCS. Would you tell us more about this?
Thank you, Dr. Gallo. FCS is a rare disorder, as you had mentioned. We do know that early recognition and appropriate referral to the key specialists are critical in the evaluation and management of this condition. The key symptoms, of course, include recurrent episodes of acute pancreatitis, episodes of abdominal pain, which may not be diagnosed as acute pancreatitis, fatigue, as well as neurocognitive symptoms such as the brain fog. The initial identification of FCS is typically by the detection of severely elevated fasting triglycerides, particularly in those individuals who are younger.
Patients with severe hypertriglyceridemia might be actually signaled at first by the lab receiving a plasma that looks lipemic. This is often the first point of suspicion of hypertriglyceridemia. Apart from that, clinical signs of hypertriglyceridemia might include, and these are probably the most frequent one, recurrent abdominal pain. And sometimes, but this is less frequent, some eruptive xanthomas, particularly on the trunk, on the back, and buttocks might also appear. These are transitory, so might not be perceived and really might not get the patient suspicious about something specific like FCS going on. Other clinical symptoms of signs that might be found are hepatomegaly and splenomegaly, and sometimes the patient, when is directly asked about this, they might also report some neurological symptoms like a brain fog, for example. Often this diagnosis is really delayed by the fact that patients are firstly addressed to the emergency department, for example, for recurrent abdominal pains, but a specific investigation of the hypertriglyceridemia might not follow, and this is what happens sometimes months or years later when this persistent hypertriglyceridemia is not controlled by treatment. And this is where patients are finally addressed to an endocrinologist or a specialist that might start investigations for hypertriglyceridemia. So how do you distinguish FCS from other metabolic disorders?
In an effort to help clinicians more readily diagnose patients with FCS, there have been the development of at least 2 separate scoring systems. These take into account the patient's age, their BMI, whether or not they've had a history of pancreatitis, the presence of secondary risk factors, as I had mentioned before, the environmental risk factors that might contribute to hypertriglyceridemia, and finally, the cardinal feature, which is a marked elevation in the serum triglyceride levels, usually greater than 880 milligrams per deciliter, but more often patients have triglyceride levels that are in the thousands. It is important to note that the index of suspicion is highest in those patients with high triglycerides who are being treated with conventional lipid-lowering therapies and yet are not seeing reductions in their triglyceride values. And that is partly because FCS has been historically treated with severe restriction in dietary fat consumption.
Thank you very much. So indeed, some scoring systems have been developed which combine this clinical and biological criteria to help distinguish this more or less severe forms. But it's true that there are some overlapping conditions, mostly in most metabolic patients, like with overweight and diabetes, that might make this diagnosis quite challenging. So what is the impact of acute pancreatitis in FCS?
Thank you for that question. Acute pancreatitis is, of course, one of the cardinal clinical signs of FCS. We do know that patients will typically not just have one, but many episodes, which are generally unpredictable. So patients might have one episode now, and some might come in the following months with several episodes. Sometimes they can go for years between episodes, and the reason for that is not clear. We know that these episodes of acute pancreatitis can range from mild to life-threatening, with the risk of potentially developing pancreatic necrosis. And the way I like to describe this is that necrosis is to the pancreas what a myocardial infarction is to the heart. So there is actually tissue which is becoming ischemic and dying. These patients can also have systemic inflammatory response syndrome, which can be sometimes very difficult to differentiate from sepsis. And of course, in the most severe forms of acute pancreatitis, some patients can go on to have both single and multi-system organ failure. There are, of course, long-term health consequences to having these episodes of acute and recurrent acute pancreatitis, including the development of chronic pancreatitis. And pancreatitis or chronic pancreatitis is a risk factor for developing both diabetes and exocrine insufficiency, which is a maldigestive disorder where there is a failure of the pancreas to produce enough pancreatic lipase to help digest dietary fat. We do know that acute pancreatitis is associated with a high healthcare burden. In the United States alone, there are nearly 300,000 annual admissions for acute pancreatitis, and the costs associated with caring for this disease are pretty close to $5 to $6 billion a year. And finally, we can never underestimate the psychosocial and quality of life impacts on both patients and their caregivers, particularly in those patients who have recurrent acute pancreatitis or require frequent hospitalizations.
Thank you very much. I have a spontaneous question from the lipidologist to the gastroenterologist. Can we say that acute pancreatitis that are associated to hypertriglyceridemia are more severe than other forms of acute pancreatitis from different etiologies?
Yes, that has been shown in many studies over the last several years. And that likely has something to do with the fact that when lipase hydrolyzes triglycerides, there is a release of free fatty acids, which we know are toxic to Aschner cells of the pancreas. And if there is an elaboration of increased quantities, particularly of unsaturated free fatty acids, there seems to be an increased risk of developing both single and multi-system organ failure.
This is very interesting. Thank you very much, Dr. Singh. So what is the genetic pattern in FCS? What family genetic testing approaches do you recommend?
We should all remember that FCS is a monogenic form of hypertriglyceridemia. It is most typically autosomal recessive, but digenic forms can occur. Siblings will have an approximately 25% chance of also having FCS, 50% chance of being a heterozygous carrier, and a 25% chance of not inheriting either pathogenic variant. Genetic screening should be offered to all siblings of individuals with genetically confirmed FCS. FCS is caused by a biallelic loss of function, homozygous, compound heterozygous, and double heterozygous pathogenic variants in lipoprotein lipase or other genes required for regulating lipoprotein lipase activity. It's important to note that genetic testing for FCS is not widely available and can be expensive and is not always covered by insurance. However, with time, we are finding that more and more insurance carriers are actually covering this, particularly here in the United States.
Thank you very much, Dr. Singh. So if we want to resume to 3 key messages from these questions on this first part of this podcast, we can say that FCS is a rare genetic disease that it is associated with an increased risk of acute pancreatitis, which might be particularly severe in these patients, and that currently genetic screening is not widely available, but should be a screening of the family should be widely endorsed.
So now that we've diagnosed our patient with FCS, the next thing we have to consider is how to best treat and monitor our patient who has FCS. This largely focuses on managing symptoms, reducing triglyceride levels, and preventing complications. The cornerstone of treatment is lifelong adherence to a very low-fat diet, often less than 15 to 20 grams per day, to reduce the accumulation of chylomicrons. Nutritional intervention should be individualized based on a patient's estimated nutritional needs. Medications for FCS have variable efficacy. They include fibrates, omega-3 fatty acids, and orlistat, which is a lipase inhibitor. More recently, melanosorsen, an ApoC3 inhibitor, was approved for FCS therapy in Europe for adults, and more recently, olezarsen was FDA approved for the treatment of FCS in adults. Regular monitoring includes routine blood tests to monitor triglyceride levels and check for complications, including pancreatitis. While the American College of Cardiology advocates for checking fasting triglyceride levels, but it should be noted that non-fasting triglyceride levels better assess the risk of developing pancreatitis. So I think it's important for clinicians who are caring for FCS patients to recognize that fasting doesn't give you the whole picture. So sometimes ensuring that the non-fasting triglycerides are also to some extent controlled and well below 1,000, preferably below 500, is really a target that we should be aiming for. If you can reduce the risk of recurrent episodes of acute pancreatitis, you will reduce the risk of developing chronic pancreatitis, which has long-term consequences that include chronic abdominal pain, diabetes, as well as exocrine insufficiency, which requires a separate lifelong treatment. So I think it sort of behooves the practitioner to ensure that they can control the number of episodes of acute pancreatitis to the best of their ability. And I think the newer treatments are getting us a little bit closer to that goal. And finally, yearly eye exams should be conducted to ensure that the vessels in the eye and the optic nerve are not being affected. Now, Professor Gallo, let's discuss some questions submitted by our audience about the current challenges and managing FCS. What are the current treatment options for FCS?
Thank you for this question. So, as you were already saying, the main treatment for FCS has long been the dietary management with a very low fat intake diet. And this is really the cornerstone for treatment for FCS. Current common lipid-lowering treatments are known not to be as efficacious in FCS. typically fibrates or omega-3 fatty acids might be trialed in patients with FCS, but often the response is very poor. So the cornerstone of the treatment is really on diet, and diet should be really adjusted according to the patient's need, but most of all, trying to avoid an overcharge in non-fasting triglyceridemia.
How effective are current treatment strategies?
So dietary management is challenging for FCS, for patients living with FCS. More than 90% of patients report difficulty managing their fat intake. And 55% experience symptoms such as food cravings, dry skin, and mood changes with dietary adherence. So patients with FCS report an extremely fat-restricted diet as an isolating experience, which prevents them from being included and participating into social settings at times due to food restrictions, and which makes also the traveling and attending family gatherings quite difficult. So nutritional intervention, as I was saying, should be individualized based on each patient's estimated nutrient needs. As to pharmacological treatment, most of patients with FCS have also tried fibrates, statins, and omega-3 fatty acids, apart from other homeopathic, naturopathic medications. But as I was saying, the change is really insignificant and the efficacy is really poor when existent. Novel treatments that target some key enzymes in the LPM activity, such as ApoC3 inhibitors, volanesorsen and olezarsen, as Professor Singh was already alluding to, have emerged as some promising therapeutic options in this condition.
Thank you for that, Dr. Gallo. We all know that following a very low-fat diet can be very challenging. So I think one other question that often comes up is, what is the best dietary management plan for patients with FCS?
Well, just to have a picture of how challenging it is, the guidelines currently recommend to limit fat to 15 to 20 grams per day, which corresponds to 10 to 15% of the total daily energy intake. And this is where most of the challenge actually resides for these patients. It's also recommended to choose complex carbohydrate foods while limiting simple or refined carbohydrates, and to supplement with fat-soluble vitamins, mineral, and medium-chain triglyceride oil, because they help in supporting with the energetic needs for the patients. Of course, in case of overweight or obesity, some adjustment of calories for weight management should be also considered. Recommended foods include vegetables, all grains, legumes, some lean protein foods, fruits in limited amounts, and some fat-free milk products without added sugar. Of course, alcohol and products that are high in sugar should be avoided in FCS patients. And as I was saying, medium chain triglyceride oils can provide some supplemental calories and fat without requiring the chylomicron transport. So that can be an interesting option that patients can really benefit from in order to have some energetic apports.
And finally, how can MDT or multidisciplinary collaboration improve outcomes for patients with FCS? And how can we best support patients with FCS? I also think one of the things that makes this challenging is that, these patients, especially those with abdominal pain and acute pancreatitis, are largely coming to hospital-based settings, right? and they're almost never going to be diagnosed in that hospitalization, or maybe there's first several hospitalizations, right? So I think that's important to keep in mind. So when they come to the hospitals, they're seeing ER physicians, they're seeing internists, they may get a GI consult. I don't even think that most of these patients would come across a lipid specialist at any time while they're inpatients. But once they get out, they're more likely to see somebody in the outpatient setting, where the diagnosis is more likely to be made. So I guess that's one of the challenges here is just it's the setting at which where patients are presenting and where they're actually getting the diagnosis.
Gastroenterologists, lipidologists, and endocrinologists have to work together because sometimes the diagnosis come too late when a complication has already occurred, and there is a need for a continuous dialogue between these different specialists. So the role of rare disease clinics in putting together this multidisciplinary team is really important. This means that the role of dietitians is really fundamental for guiding patients into a more adapted and personalized dietary plan. But this also requires that dietitians are really educated in FCS specific nutritional needs. And so true knowledge of what ultra low fat means to optimize outcomes and confidence in suggested treatment plans. Of course, apart from dietitians, the psychosocial burden that we're already talking about is something that should be also taken care of. And so the intervention of psychologists is fundamental.
And in the United States, there is an organization known as the FCS Foundation, which has been very active in patient advocacy as well as caregiver support for these individuals who are afflicted with FCS. They have also been very active in ensuring patients getting access to required medications, especially as newer treatments are being approved, as well as ensuring that there is support for conducting research into this condition so that we may have better ways to evaluate and manage them in the future.
Indeed. For Europe, there is the FH Europe Foundation, which is also a patient organization that is following this good example of the FCS Foundation and providing a lot of educational activities for patients living with FCS.
So to recap, one of the cornerstones for treating FCS is adherence to a very low-fat diet, less than 15 to 20 grams per day. Conventional lipid-lowering therapies tend to be less effective for managing the severe hypertriglyceridemia that affects these patients. And finally, there are two new therapies approved that focus on ApoC3 inhibition that include volanesorsen and olezarsen, which appear to be emerging and effective treatments for managing the severe hypertriglyceridemia in FCS. It is important to note that the care often needs to be managed by a multidisciplinary group of specialists that include a lipidologist, a gastroenterologist, as well as individuals who specialize in diet and nutrition. Finally, I think it's important if you have a rare condition such as FCS that you look to patient support and advocacy groups as they can help you navigate towards referral and management by the appropriate specialists and provide recipes that actually incorporate the concepts of a very low-fat diet and help you connect with other patients who are afflicted with this condition. Now we're going to move into the new frontiers of FCS, a look to the future.
So as we've already said, there's been some new development in the treatment for this condition by the identification of novel targets. These two specific enzymes that have been targeted for novel treatment development are ApoC3 and angiopoietin-like 3. These two enzymes have key roles in the lipid metabolism because these are two inhibitors of the LPL activity. So they limit the hepatic clearance of chylomicron VLDL ranulins. So have emerged as a promising therapeutic target for FCS. Treatments that target ApoC3 and angiopoietin-like-3 have been developed according to novel technologies, and we mostly have antisense oligonucleotide therapies or small interfering RNA therapies. Among the molecules that target ApoC3, the ASO, so the antisense oligonucleotides, are volanesorsen and olezarsen. And among the small interfering RNA therapy, the plozasiran has been recently developed. As to the treatments that target angiopoietin-like-3, monoclonal antibody evinacumab and antisense oligonucleotide vupanorsen have been discontinued in the development for FCS treatments. Must be known that these treatments are LPL dependent, and so they have been proven not to be efficacious and not to be working in patients with LPL defective genetic disease. Novel small interfering RNA therapies targeting angiopoietin-like-3 are being developed, and the two molecules are zodasiran and solbinsiran. So these treatments represent the novel perspectives in the treatment for FCS, knowing that these are also the target for some gene editing therapies that are being started to be developed.
Thank you for giving us that overview of existing as well as potentially future therapies for FCS, Dr. Gallo. How do these emerging therapies address the pathophysiology of FCS?
So apolipoprotein C3, which are going to call ApoC3, and angiopoietin-like protein 3, have key roles in lipid metabolism because ApoC3 is a glycoprotein that is encoded by the ApoC3 gene that elevates plasma triglyceride levels by reducing LPL activity. So it impairs triglyceride hydrolysis, delays triglyceride clearance, and promotes hepatic VLDL secretion. On the other side, angiopoietin-like 3, a liver-synthesized protein, regulates lipid metabolism primarily through its inhibitory effects on LPL and endothelial lipase. Given their pivotal roles in lipid regulation, both ApoC3 and angiopoietin-like-3 have emerged as promising therapeutic targets for severe hypertriglyceridemia, including FCS.
Thank you for that, Dr. Gallo. And what is known about the safety and efficacy data for these RNA-targeted therapies for FCS?
So as to the therapies targeting ApoC3, we currently have some novel and significant evidence from clinical trials focused on volanesorsen, olezarsen, and plozasiran. The first treatment is a first-generation antisense oligonucleotide that targets ApoC3 and that have been associated with a 77% reduction in triglycerides concentrations. Being a highly dosed and non-selective treatment, this molecule has been associated with some significant platelet count reductions that have been sometimes led to discontinuation of the treatments. And in certain patients, injection site reactions and abdominal pain has been also observed. Treatments with results from the more recent trials with olezarsen and plozasiran that are respectively an ASO and a small interfering RNA targeting ApoC3 has shown a significant reduction in triglycerides concentrations with an overall good tolerance. It was observed in a certain number of patients abdominal pain incidents, and for olezarsen some diarrhea and headache, whereas for the plozasiran, nasopharyngitis and headache were also reported. Interestingly, both these treatments were associated with a reduced incidence of acute pancreatitis over follow-up.
Thank you for that, Dr. Gallo. It's quite exciting to see not only FDA-approved treatments, but many other RNA-based treatments that are currently under development. Are there any other novel therapies on the horizon?
So what is really an interesting and exciting perspective for the treatment of familial chylomicronemia syndrome is the gene editing technologies that work on the permanent modification of the endogenous gene expression, so that target the gene defect that is causative of this disorder. So the CRISPR-mediated inactivation of ApoC3 has been demonstrated to have protective effects against atherosclerosis in animal models, suggesting its potential role for future therapeutic applications.
Thank you, Dr. Gallo, for not only discussing current therapies, but also novel therapies that are on the horizon for treating our patients with FCS. Clearly, this is a condition where there is much hope for the future. And now with the availability of newer treatments, most recently olezarsen here in the United States, many of our FCS patients have started on this drug and have seen marked reductions and sustained reductions in their triglyceride levels. And as a result of that, we're seeing a little bit less hospitalization for acute pancreatitis. So that's generally my sort of evaluation and management paradigm, and I'm sure that will continue to evolve as we not only diagnose more individuals with this, with the expanded availability of genetic testing, but also with newer treatments that are sort of coming through the pipeline.
So novel therapies have really changed the quality of life in patients living with FCS. I have some patients that really talk to me about this because they start confessing me that they've been able to, let's say, lower down a little bit the control on this dietary constraints, and despite treatments may not protect from a peak of a hypertriglyceridemia, they still allow to go up from lower levels of triglycerides. And so when they tell me that they have for the first time experienced tried some food, they've been able to feel less impacted socially by their disease because of knowing that they had a treatment that could help them stabilize their triglyceride control. This is quite significant because it has a really huge impact on the quality of life. Other things that they also refer to me is the symptoms. They realize that being constantly at very high levels of triglycerides was associated with some latent, some underlying symptoms that they've been used to live with. And they now realize were symptoms associated with this hypertriglyceridemia, like this slight brain fog, this constant, a bit silent but still present abdominal pains after meals, or sometimes the skin that was much fatter. Sometimes they describe some troubles in the vision, in the vision. So all this is something that is changing, and they really feel this this changing after the triglycerides really go down. Thank you very much, Dr. Singh, for being here with me today and for such valuable discussion on FCS. And I'd like to thank you all for following this conversation. I hope you found it enjoyable and informative. Thank you very much.